Hi everyone. First of all, thanks to Kelly and Kirk for inviting me here today to be a respondent to this panel, and thank you to the presenters for their work, which greatly contributes to the field of rehabilitation in HIV. So as the panel's respondent, I'll be feeding back from the perspective as both a clinician working in the rehabilitation of older people with HIV and also as a researcher who has looked at frailty in people, older people with HIV in Ireland. So I've just prepared some notes here, I haven't got any slides. So from hearing these presentations, there are a couple of key areas that I'd like to feedback or offer comment on. The first is regarding frailty and service provision in the context of rehabilitation of older people living with HIV. So as we heard from Colm and Julian, there can be a higher frequency of premature ageing observed in people with HIV. And in my research looking at frailty, we did find that levels of pre-frailty were exceeded 70% in the sample we looked at. So I suppose one of the most important things that I've come to realise in clinical practice is that signs that someone is pre-frail or tipping towards the verge of full-on frailty may not always be immediately evident in routine clinical consultation. So for this reason, I believe clinical services should include screening for frailty where possible to facilitate earlier intervention. I suppose, as Julian mentioned, there are a number of different tools available in the assessment of frailty, and there's ongoing work to try and figure out which is the best to use. But for the purposes of my research and clinical practice, I have been using the Fried Index and have found it very feasible to incorporate into a clinical consultation. So as rehabilitation professionals, we may already be looking at parameters like grip strength, gait speed and physical activity levels, which are parts of the index. So rehabilitation professionals in that regard are quite well placed to administer the full index. And then I suppose in terms of service provision, we heard from Paddy and Francisco that there can be some barriers to participation for older people with HIV. Paddy's research talked about issues around uncertainty and episodic disability, while Francisco discussed the impact of hand and the unique challenges that can pose. Even elements such as seasonal changes in the weather have been highlighted as barriers to participation. And I'm from Ireland, where it is notoriously rainy and wet, and I carried out my research over the autumn and winter months, and I can definitely concur that I found the weather was a huge barrier to recruitment and retention within the research. Not much you can do about that, unfortunately, but there are lots of things we can change. So for these reasons, I suppose it is very important to design rehabilitation services that can allow for fluctuations in attendance and that can accommodate for kind of changing health status and fluctuating levels of disability over the course of clinical care. Effective service delivery means offering the right intervention to the right person in the right place at the right time. It includes self-management strategies, but also offers access to supportive clinical services when needed. So striving to have rehabilitation services that are open access is one of the ways that services can accommodate for these fluctuating levels of disability. We know that frailty is multifactorial and can result in poorer health outcomes, but fortunately we also know that it is reversible and that there is a very strong role for rehabilitation in the amelioration of frailty. The fact that frailty is so multifaceted really highlights the need for a move away from a purely medical management model and towards a more holistic biopsychosocial approach in the care of older people with HIV. Professor Harding, in his talk earlier, touched on the need for a change in values when it comes to clinical practice and the recognition of rehabilitation needs of people with HIV. And I suppose on the flip side of that, and importantly as a clinician and someone who has engaged in research, I have found that there's often a duty on us to advocate for the adequately resourced clinical services that can facilitate the delivery of quality and comprehensive care for people with HIV as they age. It's up to us really to make sure that rehabilitation for people with HIV is a priority for policymakers and service providers. Many of the speakers on this panel discussed the importance of social inclusion on resilience, cognition, quality of life and the reduction of stigma. In my research in Ireland, I also found very high levels of social isolation amongst older people with HIV. I found that the levels of social isolation were 20% higher than those of the general population of a similar age profile. It is important for rehabilitation professionals to reflect on ways that they can incorporate social participation within their rehabilitation programs that they're designing. As a physiotherapist, this could include the provision of a group-based exercise intervention, for example, and anecdotally in my experience, I have found that many people who attend such programs highlight the social benefits of attending to be just as important as the physical health benefits. Charles also highlighted the importance and the benefits of opportunities for people living with HIV to reciprocally offer and receive support and for peer learning to take place, and I personally have found that these group-based interventions are a wonderful forum for that type of knowledge exchange to happen informally. There's an important role for rehabilitation professionals in supporting older people living with HIV to also maintain their mobility and functional independence into older age, to ensure that there's no loss of important social roles and to ensure that people can carry on performing the activities that are meaningful to them. And finally, as a physiotherapist, I just want to discuss the importance of physical activity in the promotion of successful ageing from a clinical perspective. So as highlighted by Julian, we know that people living with HIV can experience premature age-related comorbidities. In my research in the cohort in Ireland, I found multimorbidity in 71% of participants I assessed. I also found low levels of physical activity to be the most frequently observed frailty-defining criteria in the sample. It was present in 66% of participants had low levels of physical activity, and this would correlate with the research to date. We also know that from longitudinal studies that exercise is one of the most effective interventions for many comorbidities. Improvements in physical activity and physical exercise tolerance can also help with feelings of uncertainty. So if an older person with HIV is more physically able to perform their employment duties, their activities of daily living, or whatever activities are important and meaningful in their own life, this can help, I suppose, to prevent the withdrawal from social roles, and it can also lower stress levels, which has benefits for cognition that have already been highlighted by Charles and Patty. So it is important as clinicians that we are considerate of the types of physical activity that we are recommending, and that we strive to ensure that activity prescription is enjoyable, engaging, sustainable and meaningful, to ensure that we are delivering an intervention that targets the physical, cognitive and mental well-being and is truly person-centred. And finally, I'd just like to comment on the notion of shared learning and being a resource for colleagues. So ageing with HIV presents as an intersection of many specialities within the practice of healthcare, including gerontology, infectious diseases and neurology, to name a few. I truly believe it is important to share learning with colleagues who work in adjacent specialities who may not be as familiar with the effects of ageing and HIV, and to strive to become a resource for others in your field. So this is a very emerging area for physiotherapy in Ireland, and the service I have set up is the first of its kind. The development of this service is only made possible through strong collaboration with both Canada and the UK, where services are more established, and this has set off a cascade of knowledge sharing which has allowed me to further share my learning both locally in Ireland and in the wider profession. So to sum up, the main takeaway points I would take from this wonderful panel is just to consider screening for frailty within your clinical practice where feasible and appropriate, to try to incorporate social elements within your rehabilitation approach, and to encourage physical activity as much as possible to offset the effects of multimorbidity and physical function. Remember to share your and others' knowledge with not only the people you are offering rehabilitation to, but also with your colleagues and peers. And on that note, if anyone wants to speak to me about my research or the service in Ireland, I'm here all day, so come and talk to me.
Thank you.